So we've set up a separated COVID zone as part of our medical surgical inpatient unit in order to have a designated area to take care of COVID positive patients in a way that minimizes unnecessary foot traffic and keeps them separated from the general patient population, with plans to expand out should that be required. Patients who are admitted with any respiratory concern, not just COVID, the main thing we are looking at is their ability to get oxygen into their blood. And so a medical term called hypoxia is the primary concern that we have with these patients, and would be a patient who is not getting enough oxygen into their bloodstream would be a patient that we would want to keep in the hospital to be able to monitor more closely. Because the virus is spread in respiratory droplets, its potential to spread with cough in the general public is one thing. In the hospital setting, where we're doing interventions, when we give people supplemental oxygen, whether it's through nasal prongs or a mask or even in an intubated setting, that can cause aerosolization, which is a term that means that the liquid lining is turned into a gas and then is spread throughout the room. And because of that, we have to be very cautious in the care we provide these patients, because even the things we do to provide them care and to treat their ailment can then increase the risk for infection to our staff members who are present in the room with them. You know, certainly in the hospital we already have infection control standards, and we have and had protocols in place to help minimize risk for infectious patients. The biggest difference with COVID is the volume, the number of patients who now have a concern for spread. Whereas, you know, a patient with tuberculosis or even the influenza would have many of these similar precautions, but those ailments are much fewer and more controlled, versus this is so widespread and the infection risk is elevated to staff to such a degree that it's made us have to kind of adapt those procedures that we already have on a more widespread basis. Our plan is to have the equipment and staff training to be able to take care of as sick of patients as we may be called upon to take care of. Our goal is always going to be to get patients to locations that have more subspecialty training and more dedicated focus to this level of critically ill patients. But in a global pandemic setting, we also have to be prepared that may not always be an option. And in that case, we are doing everything we can to facilitate that care here for as long as may be necessary.